the question today is about whether ATG remains the standard of care for GvHD prophylaxis, or post-transplant cyclophosphamide is going to take over. I think we have a lot of data, retrospective studies, registry-based studies, phase 2 trials, phase 3 randomized trials, demonstrating that ATG is clearly a powerful tool for GvHD prophylaxis prior to allo transplant, and it is recommended when it comes to matched unrelated donors based on the phase 3 randomized trials. We also know that this is also true in the both in the myeloablative conditioning setting and in the reduced intensity conditioning setting. More recently, we've seen the advent of high-dose post-transplant cyclophosphamide, thanks to the great work from the Johns Hopkins group, and PTCy, let's call it PTCy, proved to be extremely powerful and feasible in the haploidentical transplant setting for GvHD prophylaxis. And this has allowed actually the widespread and expansion of the use of haplodonor. And this has been really a huge achievement in the field of allotransplant. Now, the question, of course, is if PTCy is a good treatment option, good GvHD prophylaxis in the haplo setting, why can't we use it in other transplant setting? It's not an easy question, and the answer is not straightforward. For instance, when you look to the registry data, obviously results are not always the same from different sources. When it comes to the mismatched donors allotransplant setting, like 9 out of 10, we have data from the registry showing that probably PTCy is doing better than ATG. You have also data showing that the results are the same when it comes to matched unrelated donors or siblings. So lots of controversies there. And we may be able to solve this from a randomized trial. And we had such trial, phase 2 randomized trial, focusing exclusively on a reduced intensity conditioning setting. And the first results were presented at the EBMT 2021 virtual meeting, showing that actually when you use a backbone conditioning with fludarabine, IV busulfan, plus ATG for GvHD prophylaxis, or post-transplant cyclophosphamide, actually the results are the same when it comes to the main outcome, namely acute GvHD incidence, chronic GvHD incidence, but also disease-free survival, and most importantly, transplant-related mortality or non-relapse mortality. So you can appreciate, I think, post-transplant cyclophosphamide is definitely a major breakthrough in our field, but still ATG remains a very well-established treatment modality for GvHD prophylaxis. So this is really very exciting, and I think we really need to continue and dig deeper into these different transplant settings to figure out what would be the optimal GvHD prophylaxis, and maybe the solution will come from actually combining both ATG and post-transplant cyclophosphamide, as we have published this in different series, especially if you're using peripheral blood stem cells. So this is really going to be very exciting and will have a lot to do for the next few years.